common problem, or the common factor in all of this is it's really not a sleep problem. It's a breathing problem.
Right.
At the intersection of airway, sleep, dentistry, and whole body health, 3 leading experts come together for one evidence-driven conversation. Dr. Barry Raphael, integrative orthodontist and co-founder of the Airway Collaborative. Dr. Richard Stevenson, award-winning educator, author, and authority in restorative dentistry. Dr. Mark Cruz, respected lecturer, clinician, and contributor to national dental research, where science meets clinical insight. This is Airway Nexus.
Rich, how are you doing?
Hey, Mark, I'm doing great.
Good.
So, what are we talking about today?
Yeah, I thought we would talk about this interesting study that actually was sent to me by my son, and he thought it was really very interesting because he's really into AI.
Sure.
And he saw this, and of course in healthcare, and so he saw this. It was published in Nature Medicine.
Yep.
And it was published in February, so just a few months ago. And the title is A Multimodal Sleep Foundation Model for Disease Prediction. And the whole study is really about using AI and machine learning and looking at data from a significant amount of data from 585,000 hours of sleep data from 65,000 patients. So it's really large data. And so they were implementing a model, they call it the Sleep Foundation model, applying it to the various channels of a PSD or polysomnogram to pick up on patterns as it relates to disease incidence or risk for medical morbidities. And I thought it was pretty interesting. I don't know what your thoughts were.
No, I thought it was pretty interesting too. I mean, you got about more than 500,000 hours of data from a huge cohort, 65,000 participants. So I'm kind of doing the math. They all slept for at least 8 hours. That alone is pretty remarkable, particularly if it's a night of polysomnography. So, that's pretty amazing. But, the thing that's incredible was that, they were really strongly correlating in dementia, heart failure, stroke, kidney disease, things that, affect us all. And very, very interesting. I thought it was also kind of interesting that they made the point about that normally you would be looking at MRI for the same data set, and yet they could do it in a less invasive, more cost-effective manner. And that was pretty cool. I think it's pretty strong paper, but at the same time, it's kind of also about what they didn't say, Mm-hmm. And so when we look at this kind of stuff, Mark, and we see these things all the time, we're thinking, oh my gosh, who's asking the why? What's really happening behind the sleep information itself? Let's try to unpack that a little bit better. And I think we all know, and we know that they're I don't know if you would say that necessarily they missed it, but let's just say that there wasn't clarity in terms of how the airway is directly involved in this whole process. What do you think about that?
Yeah, I think it's an example of the old saying, "Don't let your education get in the way of your learning." That the orthodoxy is so stilted, right. Where they are seeing the problem the way it's been seen, so orthodox. And in the introduction, one of the things that grabbed me right away is they start introducing how sleep is related to, all these chronic diseases and conditions and its medical comorbidities, and that it's kind of equivocal, this association between sleep and disease. And I'm kind of going, really? I don't think so. There are really good studies showing causation with all of these chronic conditions, whether it's cardiovascular, metabolic. You're looking at cognitive, neurocognitive. There's so much data out there. So I was a little puzzled about it. So when I read a paper and I'm hearing it in that context, I'm already a little bit, I don't want to say cynical about the authors and what they're going to say, but I'm going to maybe be a little bit more jaundiced-eyed, if you will, in reading through the details. So that's one thing. When they talked about MRIs, first of all, an MRI is not really a diagnostic test that the provider would normally use, right? It's not like you go in there and say, here's a functional MRI. A polysomnogram is a study that can be prescribed by the physician that insurance recognizes. But medical insurance, it's another thing to say you need a functional MRI or diffusion tensor imaging, which is what a lot of the studies are based on that are academic, that look at damage to different parts of the brain that are associated with chronic intermittent hypoxia. But those were not studies that were meant necessarily to assess an individual patient as much as the pathophysiology of the condition of sleep apnea. So I thought that was kind of interesting that they brought that up, because that would never even enter as a decision anyway, I don't think, in the average sleep physician's mind to say, I'm going to send you an MRI, let alone say functional MRI.
Yeah, that I agree. I wanted to ask you, because the amount of experience and knowledge you have in this area is huge. These are the kinds of things that we're sort of trying to prevent by recognizing them earlier in life, and somehow people are missing this. That this is a, we talk about this a lot. We're talking about kind of the end stage of a disease, actually, right, Mark? And so, just even the fact that we say that implies that there's an arc, there's a trajectory that can be predicted much, much earlier, and we can intervene. And this is exactly what we do. We have tangible results, medical metrics that prove outcomes are better, happier patients. We move the needle pretty drastically in some patients in a positive way, without waiting until the very end. And that's one of the things that kind of resonates with me, is that I'm looking at this going, it's really not, it's great, I get it, but at the same time, it's not that surprising. If I have patients that have problems with respiration while they're sleeping, and they're not saturated well, and they've got a lot of breathing effort and high arousal events, if that's all happening while they're sleeping, that's no surprise to me. That they're why were they even prescribed this PSG in the first place? So I don't know. I think it.
Well, let me jump in.
This is not the cohort anyway that we normally even spend much time treating. We try to get them into treatment with the medical community, but sometimes they'll circle back and we'll help them as well. But a lot of that can be looked at way in advance before these things happen.
Well, that's exactly right, and this is exactly what this podcast is about. And what we're about is let's not be waiting till the end stage. I mean, again, going back to the studies, it's very well documented what's going to happen to the brain due to many years, oftentimes decades, of chronic intermittent hypoxia. You're going to have damage to different areas of the brain that end up in end stage disease. Why would we wait to that? And yet in this study, they're using studies that are prescribed to a selected population, which one of the comments that was made in the discussion was the weakness of the study was there was a selection bias. Well, of course, because they're actually looking at disease that's already end stage. It's not even beginning. They didn't really get into the details of the study, other than that they did use American Academy of Sleep Medicine studies, and they use different criteria to kind of have uniformity across the four centers from which they gathered the PSGs. But I think the bigger issue is, to me, is the elephant in the room is this is a reflection of the problems with our healthcare system, that we're focused on the problem once it's already happened. All these problems, metabolic problems, obesity. I mean, even cancer. I mean, we talked about the what was okay. Sidebar. What was really, to me, very important in the paper is the statistical analysis that they made in the machine learning, correlating the data from the different channels of the study with the different medical comorbidities, and they broke it down looking at area under the curve. So they looked at ROC curves, and almost all of the correlations were 0.8 or above, meaning that the sensitivity and the specificity were so high that that is another way of saying it's very accurate, right? So so when you get to 1, that means area under the curve, which doesn't happen 100%. That means that you've got a condition that really doesn't occur, where sensitivity and specificity are very, very high. So few false negatives, few false positives. So the data that you get, it's very strong. Another way of saying it's very strong. So to me, that was like, wow, well, we already know that, but they actually were acknowledging that with the analysis and the machine learning. The other thing that I think was really interesting from an AI point of view is, and that what AI can do, and that I will predict in the future that it will be malpractice if the provider is not using AI as an aid in diagnostics, in that it could look at very big data sets and pick up patterns that are very difficult for even a very seasoned clinician to look at. And some of the things that I thought, to me, that were compelling were, excuse me, is that we're looking at the association of the different stages of sleep with the different, morbidities. Like, for instance, Alzheimer's, they were looking at the correlation with that cohort, that sample had less N3 sleep or slow wave delta sleep, the deep sleep right before REM. And of course, we already know that. And why is that? And the reason is that during slow wave sleep, you have what's called the glymphatic system. And that's where the glial cells, or the brain cells, shrink, where the blood-brain barrier opens and all the metabolic waste from the brain gets to spill out and cleanse. So all the reactive oxygen species from the metabolic work that the glial cells, as every cell, will go through, their metabolic byproducts, that if it's like you're swimming in your own poop, right? So you want to, it's got to get rid of it. And so the brain doesn't have its own lymphatic system like the rest of the body. And so what they found some years ago is that during slow wave sleep, deep sleep, right before REM, those cells really shrink, and what happens is the cerebrospinal fluid can cleanse and go through the nooks and crannies and pick up all the metabolic product and cleanse it. Well, in those individuals that aren't in slow wave delta sleep for very long, they're not able to have that cleansing effect, if you will. And so what happens is it stimulates the deposition of tau and beta amyloid, which is what we know essentially causes Alzheimer's. So I thought that was really interesting. They also talked a little bit about what happens when you have REM versus just slow sleep. So I thought that part of the machine learning from the AI was really, really very interesting.
Yeah, I will.
A lot of things, but
yeah, I mean, that's absolutely fascinating to me, and I get excited about the role that we can play as dentists in keeping patients from even being in this. You know, my goal is that a patient never has to have a PSG ordered. You know.
Right.
Yeah,
well,
right. I mean, and so it's, and I think that it's going to take some time before that message gets out for sure. I think so. If we're just looking at this cohort that has a sleep study was ordered, they were able to make all of these amazingly accurate correlations. 130 different diseases were correlated. It's pretty cool. But at the same time, I'm thinking that's great, but how did these people end up here to begin with? And no one seems to talk about that. There's really not a discussion about what can be done about this. And I think, like you said about modern medicine, we get kind of so excited about these sort of things, but does it really? Now what? Sort of like a now what?
I call that disease management, right? Because that's how we get paid.
Right.
To manage disease, not so much to obviate or cure it, if you will.
Mm-hmm.
So here's the problem. The common problem, or the common factor in all of this is it's really not a sleep problem. It's a breathing problem.
Right.
Or the channel in a sleep study
Right.
are actually looking specifically at flow limitation, whether it's looking at the chest belt or the effort from the abdomen,
Right.
Flow limitation and through the oral pharyngeal complex to the nose, and so that's where our role as dentists come in. If you understand that the problem really starts with flow limitation, and why is that a problem, is because if you have flow limitation, that gets the brain very excited. So the autonomic nervous system upregulates, and it's really what causes a lot of the chronic problems. So when it's end stage, most of these patients that have these diseases that are end stage, it's because they've already been hammered from chronic intermittent hypoxia. So it's kind of like what I remember Ron Harper from the UCLA Brain Research Institute, one of the most published researchers on sleep apnea, would say it's really not so much the chronic intermittent hypoxia or the hypoxia per se that's going to kill the person. It's the brain's or it's the autonomic nervous system's response to it.
And that's
what we're looking for when we do our screenings with a high resolution pulse oximetry. Is like we're looking at that heart rate going up because there's a dump of adrenaline, and if it doesn't, that means that there's a lot of damage to the brain. Now we won't get into the weeds about all that, but I think for those patients that are super symptomatic, but you do a sleep study and they have no apneas and hypopneas, it's this idiosyncratic, paradoxical condition that you're thinking, well, they don't have any apneas or hypopneas, but they're super symptomatic. Why are they? Well, they don't have any apneas and hypoxias because their autonomic nervous system is really healthy. It's preventing them from having that chronic intermittent hypoxia that causes end-stage disease.
And by the way, we in our daily airway practice can see that, we can measure that with
Sure.
highly sophisticated, non-invasive methodology, and we do it all the time,
Yeah.
all the time. And there are so many people out there that are suffering before they get to this stage that have been trying to find answers, and they're doing all kinds of things, as you know. And I think that it's just, this is such a great opportunity for us, because we intervene before people get to this point. But let's face it, it's going to take a lot of time for enough airway dentists and orthodontists and airway-focused clinicians to really learn how to recognize these things, to understand how to treat our patients. And unfortunately, a lot of people are going to end up in the PSG sleep lab because they're being told they're not breathing at night, and then they end up in this situation, and then we're looking at these strong correlations to all of these horrible chronic conditions that affect so many of us. And so, it's just, I'm excited about the fact that a paper like this is out and people are reading it and people are getting excited. And maybe that's just one part of the medical community starting to become more informed that sleep is causing all these issues. And we believe that it's more than sleep. And I don't think it's a belief as much as it is we have the documentation to prove that it's all really stemming from, in most cases, I mean, there are some, outliers, but most of the time, if you're not getting properly oxygenated and while you're sleeping, even if it doesn't show up as an apneic event or hypoxia, you are dealing with an autonomic nervous system that is stressed. As Harper said, it's what the autonomic nervous system does to try to fix things that causes so many downstream problems. So
Another way of saying that is sleeping is secondary to breathing. Moment to moment, you have to breathe.
Can we? I mean, we should just be saying that a lot, because it's.
Yeah, well, I say it's breathing disordered sleep, right?
Yes.
So if you have disordered breathing during the day, and a lot of people do, and they don't know it, but that's why they go to yoga class, right?
Of course.
They only order their breathing
Right.
by either a workout, meditation, yoga, in some cases, happy hour. It's disordered, and then that kind of calms you down to be where you're finally feeling like you should all the time. At the end of the day, well, you should be like that throughout the day. Right? I mean, athletes that are performing at their peak, they're optimizing their breathing function for the high metabolic demands of their activity better than maybe the next guy. And so it's about breathing. And what I find in my practice is the people that are coming in, yes, it's going to take a while for the healthcare system to change because it's so complicated. There's so many stakeholders and yada, yada, yada. And people involved that don't understand this, the bean counters and all that. But it's the patient that knows, they're searching and go, I know this isn't right with my kid or with myself. I know the snoring, and people are hearing more and more about it. You hear on the internet about taping the nose and neti pots and all these things that we didn't hear that much about before. That's the beginning of an understanding. And then when you start treating those individuals, even if it's a colleague that comes to a course and they go, oh my gosh, that's my wife, that's my husband, that's my daughter, they start, seeking treatment for themselves, and then they start telling other people because it changes their life. It's not just something like you go ahead and do a set of veneers and boy, that's nice, and then it just becomes part of your background. This actually changes the way you function and walk through the world, and it's pretty remarkable. And I think it's a grassroots effort in my mind and in my experience that we're starting to understand. And again, when I was talking about this 15, 17 years ago, it was all about sleep and making appliances. And people thought I was crazy because I was talking about these, and not everyone's doing it. And now they're doing MARPs and they're doing these things, but they're still not even talking about the breathing. They're just saying I can make your palate wider, but they're not really saying and understanding why that is and how that affects the sleep beyond maybe citing that you could breathe better through your nose. Well, what does that mean? Well, as a provider, you have to measure, and that's what we do for our patients. And what we're measuring is the autonomic nervous system. They're getting into parasympathetic coherence, and therefore the anxiety, the depression, the mood swings, the irritability starts melting away. You start brain fog, forgetfulness,
cold hands and feet,
all those things.
Unexplained, I mean, I don't want to.
Yeah.
Eczema, and just bags under your eyes and things like this. It goes on and on. There's so many things.
But that's the problem, is because there's so many things, how can it all be connected, right? It's and that's why, we talk about human systems theory. We talk about the body not working as 7 different organ systems, right? It's integrated. And we're trained in a system that looks at 7 separate organ systems as if they're functioning in isolation. And reality, they're integrated. And we in dentistry, we look at the temporomandibular joints as maybe somewhat loosely related to, the teeth and to the gums, and not much having to do with the tongue, right, and the cheeks. And yet it's all interconnected. And so, and the most important part is the breathing part, because that's part of the breathing, the airway, right? Oral cavity. I have to tell you, this morning I had a meeting with Craig Pickerel, who's the principal of patient safety, that makes the high resolution pulse oximeters. Really exciting, the new oximeter that they have, the Bluetooth that you put on the forehead, that takes care of a lot of the problems that a finger probe has. But we were talking about this study that we're ready to publish, looking at how you read oximetry, and he's really frustrated as a sleep tech that really understands flow limitation. He says, they don't really understand a lot of these sleep physicians. They're really looking at apneas and hypopneas, but they're not really looking at the arousability, if you will, from the autonomic nervous system. And one of the authors from Harvard that's in this study actually had a conversation with him, is super excited because he's now saying, you know what? We've been kind of looking at the wrong thing. It really kind of comes down to, the autonomic nervous system's response to any perturbation in gas exchange. In other words, you have flow limitation, and that can cause a kid to manifest as they say, ADD, ADHD. It could be what causes the bedwetting. It's not some bad habit because they didn't go to the bathroom before. So I think it's so complicated in many ways, and yet I see it's very simple when you really kind of understand it.
I was going to say the same thing. It's like, you said basically, how could all of this have one common origin? And you could also say, how can it not, in some respects? Because the fact that so many of these things can be explained so clearly with all these pathways that you're talking, that so well, Mark. For me, I just think, if we can circle back to this paper, this study, I think it's great, and it's not really preventative medicine, is it, Mark? It's sort of, we're just finding out a way to maybe save some healthcare dollars by looking at sleep studies to make some predictions, but in terms of really changing the trajectory of someone's health, we can be involved in preventing a lot of these things so much earlier.
Okay, so can I ask you, having said that, knowing what you know about airway, how many of the diseases that were on the list do you see in your own practice as downstream? They came into you maybe for a tooth problem, a dental problem.
Right.
I mean, now, do you find with this airway focus, if you will, that you're looking at the patient differently when you see that erosion or the wear patterns and the reports that really you end up finding out that they have all these end stage problems, along with the type 2 diabetes and the obesity? I mean, with knowing this as a dental provider, how has this affected you and how you see the patients and how you treat them?
But it's almost like the majority of patients that I see, once they reach a certain age, they're going to be on some kind of medication for diabetes. They're going to be on some kind of statin. They're going to be on a blood pressure medication of one kind or another. There are going to be other healthcare issues that they have. They come in to see me in the practice, and I can tell you how I used to respond to those patients, how I respond now. I used to think, oh gosh, that's really a bummer. That's just something that happens with people that get older. Aging, it kind of sucks. Now I don't think that way at all. I start to look at the correlations between all of those systemic conditions that are being treated by well-meaning, excellent medical doctors. It's not their fault. And I'm looking at other factors, other signs and symptoms that they have that I used to just blow off and say, oh, you're a grinder. And they say, oh, why do I grind? And my common response was, most likely stress. And yeah, I'm under a lot of stress. And then so we would treat them with either new restorations or some kind of a guard of some kind, and you kind of shrug your shoulders. What more can you do? And the patients played along with it as much as we did too, because what else could it be?
What do you know? You just know about teeth, right?
True. Absolutely.
Yeah.
When I
get my patients now, they come to me more and more now, are asking me because so many times when I'm asking them the questions, all those things that you just listed, I'm just thinking, this person doesn't sleep well. I start talking to them about their sleep.
Absolutely.
Right? When you start having all these symptoms and these medications. So let's go back in time when we were in dental school. All of us, when we were in dental school, I remember we were all excited. We put our white coat on and we went into the clinic, and then we were supposed to do our medical history, review of systems, ROS, HENT, right? All those systems. And we'd go through and ask them their medication. And so we're just, I think, looking back, playing doctor. Okay, I checked all the boxes. Okay, not that I could do anything about that complicated medical history, other than just to note it, as if it had anything to do with me as a dentist. I'm just making sure I don't get myself in trouble and use a vasoconstrictor on a patient that's about to have a heart attack, okay? So we kind of would do that. And then as you get into clinical practice, you kind of almost, you kind of blow it off. I mean, how many of your patients do you routinely take your blood pressure every time you do a procedure? I think most dentists do that less and less and less. Okay, we're supposed to. But now, for me, knowing what I know, and is when I see that medical history, I'm going straight to, how are you sleeping? And what happens invariably? Oh, I sleep great. I snore, but my wife doesn't like it. Or, I haven't slept well in years. And then, as you know, how we train them to ask the screening questions, it starts taking you down this road that the patient starts saying, yeah, how'd you know that? And then you ask another question and you go, wow, no one's ever really asked me that. They go into their physician, they have all these medications. Let's see, let's put your glucophage dose up a little bit. Looks like you're having problems not even thinking about asking whether they've got a sleep problem, right? Sleep apnea or whatever the case. So I think, that's where it's very exciting to be a dentist when you start using that airway focus, because it doesn't replace us doing our dentistry. It just gives you a better context to understand the etiology of the problem, right? Whether it's wear, looseness of the teeth, loss of bone, bleeding because they're mouth breathing and they've got that chronic, all those things that I think gives a different context. So I think patients appreciate that. So it's different, right, for you now?
Totally, completely different.
It makes sense.
Pardon me?
It makes sense, right? It's not.
Of course, yeah, and it's just I in my chairside discussions with patients are so different now,
Yeah.
and it's fascinating because they have hope now, and they've finally found something that is gonna put them on the path to wellness, and they're excited about it. And so I love it. I wish I were younger so I could practice longer. I mean it, because I now finally, after 40 years, we both are celebrating our 40th years as dentists. It seems like we just started. I'm not supposed to say that.
I've been practicing 10 years, man. Hey,
I know.
Right, Rich. It is exciting, but don't you also find that it's more rewarding, the conversations I have with my patients, that they really, what I find is that the physician is caught up in a system that's broken, and you talk to them and they know that they're frustrated, and they're saying, I just kind of have to get through and take care of this symptom du jour. And the patients start saying, yeah, they're putting me on this and they can't figure it out. And I've gone to 3 or 4 different specialists and no one can figure out. And the patient's frustrated to where when you start engaging them in a conversation like that, like you say, they have hope. They go, oh, wait a second. Someone's actually trying to figure it out in a comprehensive diagnostic way. And for me, I have found that my referrals to my physician counterparts is a lot more effective. Saying, okay, maybe we should start talking about this, and then I find those conversations with my colleagues, medical colleagues, are more collegial as a result of it as well, versus like, stick to teeth, buddy. It's more like, well, tell me a little bit about, you did that high resolution pulse oximetry and you had noticed yada 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 yada. That makes a lot of sense. What do you think? So then I start getting referrals from them. And I think that's just the way it should be. It's just more collegial. And again, coming down to how we breathe. And that's our role, because as dentists, we're dealing with the facial skeleton, right? More than anyone. And that's where the kinks in the hose are: the back of the tongue and the nose.
Right.
And the nose is just the second floor of a 2-story home, of which the palate is the ceiling of the first floor.
Ceiling of the first floor, right.
Right. And so when you start thinking about it and you start talking to the patients about it, and you start understanding that, I could deal with that wear and that tear and stop the bruxism, instead of giving you a piece of acrylic to wear at night, we can actually stop that by improving that flow. And the patients come back and go, wow, I just feel so much better. I'm sleeping better. And the restorations aren't breaking all the time. Joint symptoms are ameliorated, or they go away. And so going back to the paper, I think it was really interesting. Large data sets, in summary, AI, machine learning, pattern recognition that helps the provider. Yep. And we're all in this together in healthcare, and it's really about the patient. And I think it is exciting to really start looking at this, our patients, with a different set of eyes. So maybe we conclude our podcast with that, and if you have maybe a learning moment of the week. I know you were gone last week, teaching a course up north, but any learning moments that you want to share?
Basically that in my, I teach these general dentistry fundamentals courses, right? And so we start off with, diagnosis, and then we get into things like preparation designs, adhesion, posterior work, anterior work. We have occlusion in there. We talk about implant restorative connections and the full mouth rehabilitation approach, so this is kind of 7-part series. It's a lot of hands-on, but since becoming, I would say, enlightened, quite frankly, and have a deeper understanding of the human body and how our role is so important to the trajectory of people's health, I've started implementing, Mark, airway related of kind of I would say a modifier or a deeper understanding level to every single course we have. So
Airway aware.
Airway aware. So if you look at, there's 4 points on the diamond, where you have periodontal, and you have biomechanical, you have functional, and you have aesthetics or dental facial analysis. You look at these 4 areas. Airway impacts them all, and it cannot be dissected out as a 5th area, which would be so convenient to do. Oh, we have 5 now. No, it's not.
It's the foundation.
Yeah, it's totally. It's interwoven everywhere. And so my learning moment was I started to incorporate this in my lecture, and the response from everybody was very positive. People are just getting excited, like, okay, how do I learn more? Where do I go to be able to start to see the things that you're seeing and you're talking about? So it was great. There were 26 dentists from all over the United States that came to this course for 3 days, and they're waiting for some kind of a program they can join, something that we have. So that basically we have designed, and so that's kind of cool.
That's my learning moment. Nice segue. That's my learning moment. You know what my learning moment was? You and I coming up with the Airway Nexus Fellowship. I mean, I'm so excited about that, Rich. This happened this last week.
I can hardly sleep. I'm so excited.
We'll dedicate the next podcast or series of podcasts.
We should
to talk a little bit more about that.
Right. I agree. I think we should, because any dentist hearing this is going to want to learn more about what it's all about, for sure. And
I'm confident it's going to change dentistry. Those are big words, but the reason is that we finally figured out how really to package it in a way. First of all, as you said, dentists need a system. Otherwise, you get overwhelmed with a lot of information, but you don't know how to use it.
Right.
Because at the end of the day, on Monday, you've got to treat a patient. So number one is a system that works for you in working through the entire timeline of the airway from formative years all the way through maturity. Okay, so that's one thing. And then the other thing that's exciting is that our residents, if you will, because it's more like a residency, actually we provide patients for them.
Oh, I know.
And like in a residency in a hospital or a dental school, they're going to be able to actually do the procedures in the context after they learn, right?
Yeah.
So I'm excited. What I learned this week is our conversation going back and forth that, yes, we finally have the answer. I cannot wait to get the word out. And I think that's what we'll do over the course of the next few podcasts is talk about how both of us have come together with Barry and our faculty, world-class faculty, both physicians and dentists, to really really provide a system that really makes sense beyond just a widget. So
Yeah.
I look forward to that. Rich, again,
Thanks.
thanks for a great podcast, and I'll look forward to our next podcast next
Yeah, me
week.
too, Mark. It was great talking with you, and can't wait to talk more about the Airway Nexus.
Yeah, sounds great. Good. All right. Talk to you later, Rich. Take care.
Bye, Mark.